it comes up around frailty and front door frailty when we go on sites a lot, is for everybody to feel at the end of this, you can go on site, understand enough about frailty and CGA that you can have those conversations, and understand enough that you can go on site and ask the right questions and recognize when they're doing CGA right from when they're doing it badly, when it's a good place and when it's not. Can you just go on to the next slide, Vanessa? No. And recognize it. You may not necessarily always, I think, kind of be able to say what they need to do to make it better, but it might be you need to call for help from someone else from within the team, from one of the geriatricians, someone within health and social care team about, I recognise these people are not doing it right. Can you come and help us advise? So do you want to go to the next slide? Oh, this is just really gets really stilted when you have to do the next slide bit, doesn't it? So that's what I've just said, I think, is about kind of being able to feel confident on site, ask those questions and say, what is this, what you're doing, and feel like you can give the impression that you know what you're talking about CGA, and ask those right questions, say what are you doing and what are you not. Can you go on to, so this was the bit that Rob asked me to do again. Forgive me for those who are at the team meeting, a little bit about what is frailty, and can maybe ask somebody who was there to repeat it back. So reason we think about frailty and we talk about frailty is, if you look at these two lines, we probably all recognize it, but it's difficult to quantify, is those of us that are not frail, hopefully, put myself in that category, we have some minor illness, we decompensate in our function a little bit, but we return to our baseline quickly without losing our functional dependence. So that if you look at that green line, the dip down is small. It doesn't go below the line where we go from being independent to more dependent. It doesn't last very long, and we return to our previous baseline. If you look at the red line below, those of us with frailty, we are close to not being independent and being dependent on people for other of our functional tasks before things happen. And a minor illness can result in a great loss of function. That means we then develop a dependence. And if you look at the red line, it goes down further. The time we lose our independence for is much longer. And often, as with that red line, people don't return to their baseline. So as Kevin described it in the team meeting, that bounce back ability is, we don't bounce back as far and it takes a lot longer. That's why we try and recognise frailty. And if you go on to that next slide then, Vanessa. So just for those that weren't there, frailty is best described as a state of increased vulnerability to poor resolution of homeostasis and getting back to normal after a stressor event. That's a kind of formal definition of it. And what we talked about a little bit, if you go on to the next slide, Vanessa, is lots of, so I think everywhere that I go does this. They talk about frailty as being older people, and this presumption that once you're over 65 or 75, you become frail, and what's your frailty service? We all use those words interchangeably, but it's almost that frailty has become a new word we use to describe healthcare of older people or geriatrics or whatever those services are called. And often it feels like organisations use frailty to talk about the kind of front door assessment of older people, and then have frailty and then healthcare older people wards, and what's the difference. This is just really trying to look at, not everybody who's old is frail. So as you get older, you're much more likely to become frail. But if you look at that age group of 80 to 89-year-old people, only in this series, and in some series that can be up to 50%, but only about a third of people are frail. So it is part of aging, but not an inevitable consequence of aging. And there's a difference between being elderly and being frail. And it's just challenging some of that language on site to say, when they say this is our frailty service, ask, are you talking about age related services? Are you talking about services for frail older people? What's the difference? So just being aware of that. And just going on to that next slide, Vanessa. This was that bit again, look, that we talked about there's a difference between people's frailty, disability, so what they can't do, and the functions that they've lost is easy and obvious to spot. And comorbidities we often talk about in older people having lots of illnesses. We use being on multiple medications as a proxy for that. So the more illnesses, chronic illnesses you've got, the more medication you're likely to be on. But there is a difference They three are interlinked, but you can be frail but not be disabled and not be lots of comorbidities, or you can have all three of those, including just they're different concepts. Can we go to that next slide? And this is why we look for frailty. So this is just using electronic frailty index, but it works whichever measure of frailty we use. That frailty on its own is a really good prognostic indicator for poor prognosis in older people, better for surgical outcomes, hospital admission, admission to care home, mortality, all kinds of things than other markers, than comorbidities, other illnesses or medication. So this is why we look for frailty in older people and try and manage them differently, because it does have an impact upon life expectancy and function. Can we go on to that next slide? Just really quickly, I'm sure we all see this on site. It's become de rigueur to talk about the electronic frailty index, isn't it? Everybody uses it. There are about over 70 different frailty rating and assessment scales. Because it's a syndrome rather than an illness, there is no one specific measure of frailty. So what I say when I go on site is it doesn't really matter. There's all this fuss about, oh, someone scored them as a 5 and I think they're a 6, or are they a 6 or a 7? It doesn't really matter. It's not like have you had a heart attack or not, where it's a binary question. This is a bit, there is no single measure for frailty. So getting hung up upon, we audited the ambulance service frailty scores and they weren't quite right, so we don't believe them, we're going to do them ourselves. It's not a binary thing. You're either frail or not frail. It doesn't really matter, I don't think, how people measure it. But everyone now is using clinical frailty scale. Just if we go on to the next slide, this is something I shared and I think it's gone round, and I think it's over 2 slides. I'm really sorry it couldn't get it on one to be readable, about asking a kind of self-rating scale. It feels much more patient focused about how the patient feels about frailty and how they think their function is, rather than, oh, I think you're moderately frail or you'll score 6 on a clinical frailty score. But going back to that strength-based assessment and what we all think about, but asking the patient what help that they need and making it about the patient and what extra support they need, rather than the kind of pejorative, oh, it's almost like that the Rockwood scale that I've just shown that everybody has on posts on the wall is almost like a kind of color paint chart, isn't it? You hold it up against the patient. Oh, are you a 5? Are you a 6? It feels very judgmental. Patients don't like being called frail. But using this, we've just gone to that next slide about the 7, 6, 7s, 8s, and 9s. I think it's just kind of like either asking patients or their carers to. This feels like a very different way of making frailty not a negative thing that we judge people on and offer them less good services, but saying this is a problem that you have that makes you, we need to do extra for you and treat you better as a consequence. And this is something that we recognise to improve and enhance your care, but it's about what you need. So just, I thought that was a really nice way of doing it. If we just go on to that next slide. So I think coming back now to what is CGA, this is a big mouthful. Do people understand the concept of CGA? So CGA has been defined and it, like lots of things, to look at treatments, you've got to kind of have a definition to be able to do research, as being a multidimensional, multidisciplinary process which identifies medical, social, and functional needs, and then develops an integrated and coordinated care plan to meet those needs. This is why geriatricians exist on geriatric wards in multidisciplinary teams, because this is what we do, if that makes sense. So if you're young and you go in, and I'm going to use a really pertinent example now. So I have at the moment, my elderly mother, who's 90, is in hospital and got admitted a couple of days ago. She's got a fracture of fibula. So if I broke my fibula, I would go into ED, have my foot put in plaster, and I would come home. Nobody would think about my functional or social needs, and I don't need a care plan. I need something that deals with fixing my broken ankle. My mum has gone off her legs and is now immobile and has gone from being independently mobile to needing to transfer, and as a consequence in hospital, and needs that broken fibula put in context all else that's going on with her. So that's what we need to do for frail older people. Going to the next slide. So this is there are various different versions of this flower with different words in, but and then it's not what it hold up kind of too hung up upon, but this is about looking at all those different domains of the care of an older person. So the medical care and the diagnosis, what's going on with them, what's caused their acute crisis, if anything at all, what their physical function is, so what it was like before their illness and what it is like now, so the impact that it's had, what they able to do with their ADLs, all those things, putting that in the context. And I don't know if Dennis probably isn't on this call, is he? No. But Dennis at the team meeting very much about frailty being a social construct rather than just a healthcare related one. But so this is saying, alongside those kind of bits about the immediate bits about their medical problem and the functioning impact it has, putting that on into the patient and their patient's environment. So thinking about that and their networks of care and what happens at home, and then the psychological impact of that. So for CGA, we should be doing all those domains. It is not about which questions you ask. In so many places you say, they say, here's our CGA assessment, and we've added more questions, and it's not about what questions you put in. It's just saying this has got to be holistic, multi-dimensional, multi-domain assessment, rather than it must include a question about how many cats you've got or whatever. And it's not the document, it's what you do with it, and we'll come back to that. But so, to me, this is the level of assessment. If we just go on to the next slide, is everybody who here is familiar with the Silver Book? Anybody want to shout out? Anybody heard of the Silver Book? So Silver Book was published, and Amit will correct me, was about 10 years ago, led by the BGS.
Absolutely. And you and I both were on the groups at the time.
Yeah. So it was a multi-organizational thing supported by led by the BGS with Age Concern, RCN, CSP, Royal College of OTs, every organisation you can imagine, to try and describe the ideal and best care for the first 72 hours of crisis response for older person. So it covered pre-hospital care, what should happen coming into hospital as admission avoidance, what should happen in an ED, and what should happen as acute assessment. It didn't go beyond 72 hours in hospital, but was trying to get a multidisciplinary best practice. It's been updated about and the first version was literally on paper, and they printed copies off and you could download it. It's been updated 4 years ago now, I'd say, as the Silver Book 2, which is just updating some of the evidence and best practice. And it exists as if you go to the British Geriatric Society website, like lots of the nice documents, it exists there as a virtual document where you click on it and you go to different chapters and different domains. So this is coming from the Silver Book 2, about best practice, best evidence-based practice for acute care of older people. And in this, the authors, and this is primarily led by Simon Conroy, who I'm sure will know from the Acute Frailty Network, put in 3 other words I think are really important, and I use this when I go on sites. Giles has put the link in the chat. Thank you. You're on it today. Not that you're not always, but you're much more on it than me. So this is putting in 3 other words: urgent, vital, and acute. So I think this is just, to me, this is what I use when I go on in acute hospital sites at front door frailty teams. So saying the multidimensional, multidisciplinary process identifies the urgent and vital needs of the patient and develops an integrated, coordinated acute care plan. So this is saying CGA is right to be started at time of acute crisis at the front door. It does not need to worry about their squeaky gate or whatever while they're in ED. It needs to focus on and be proportionate to their needs, what's happened there, and is a process that starts there. But I've seen it, we can't discharge this patient, we haven't completed their CGA. CGA is not an intervention that must only happen in an acute hospital. It needs to start, and the proportionate and relevant bits to their acute care need to happen there. But it doesn't mean that people have to stay until they had all their CGA done. So this is saying, when we're doing stuff at the front door, and I would ask you to ask questions about, is it about their acute needs? Is it about what needs to be sorted out urgently in hospital? Is there a way of that flowing through with the patient to the community for further follow-up? And is it proportionate to their needs? Can we go on to the next slide? So why do we do CGA? And the evidence is, if you do CGA, so in hospital, people are more likely to return home, less likely to have a functional decline as a consequence, less likely to have a cognitive decline than if they didn't, and less likely to die in hospital. So the evidence, when you start looking at evidence, talks a little bit like stroke care. We know that stroke care's got good outcomes if you go to a stroke unit where you have multidisciplinary stroke care. What's been really hard for stroke care is to pull out which bits of that make a difference. It's that the package. And when CGA was first evaluated, it was saying these are done in specialist units, so specialist elderly care wards with a specialist older person specific multidisciplinary team, so therapists, nurses, doctors who are caring for older people who do this routinely as part of routine care. If you look at this, and if you go on to the next slide, so there's some evidence it can improve the progression of frailty. There's some evidence if you do it in the community that it reduces the likelihood of hospital admission or hospital readmission. Or going back into hospital, people who come out of hospital, so if you follow it through on discharge. And there's some evidence that if you do it in the community setting as a routine thing, it reduces likelihood of going into hospital, increases likelihood of people remaining at home. And if you turn to the next slide, if we look at the outcomes, so if I talk about odds ratios, do people understand that? So in evaluating a treatment, whether it's got a good outcome or a bad outcome, the number goes up or down. It says it's comparing it to whatever the standard of care otherwise would be, giving that a reference range of 1. So if a treatment makes it 20% more likely a good outcome is going to happen, you get an odds ratio of 1.2. If it was going to be 10% worse as an outcome, it's 0.9, if that makes sense. So this is saying the numbers you need are not very big. So if you receive CGA in hospital, you're 25% more likely to return home and be at home and independent at 6 months, and 15% or 16% more likely by a year. So because these are outcomes that happen really commonly to older people, you don't need to have a very high odds ratio of it to have a really significant impact. They're less likely to be institutionalized, so 21% less likely to be institutionalized, 24% less likely to die. Again, are people familiar with the numbers needed to treat as a concept? So you can if you know how frequently something happens and you know how much you can reduce it, you can come up with the number needed to treat, and it's used in lots of drug treatment. So this new drug treatment has a number needed to treat of 30 to prevent an MI. So that's saying if I treat 30 people with this new drug, I only need to treat 30 to stop one person who would have had a heart attack from not having a heart attack, for example. Numbers needed to treat for CGA, different trials go as low as 6 and up to the mid-teens, up to 13, 17. So this is saying for maybe as low as 6 people, maybe as high as kind of 13 or 15. For every 15 people that you do a CGA on, one of them is going to be alive and in their own home who wouldn't have been at 6 months. So that it's really quite a big treatment effect. To put that in context, treating an 80-year-old for high blood pressure, you have to treat 650 people for a year to prevent one stroke or one heart attack. So we can put that in the context of lots of drug treatments we offer that we think are really effective. Lots of drug treatments got numbers needed to treat around the 100 mark. So comprehensive geriatric assessment is really, really effective. The numbers of people need to treat to show benefit are really quite low. So again, this is looking at some data from the community. What's hard, and I'll go on to this in the next side of it, is there is some conflicting evidence because people have done their trials and their populations in different ways. So, but you are much more likely, if you have CJ in the community, you're more likely to be in your own home and independent. It probably, if you look at the trials overall, CJ probably doesn't affect mortality. So the health problems you've got that are going to get you and kill you are probably going to still happen. CJ is not as much about that. It's about saying, can this maximize your functional independence and your quality of life by being more likely to be at home than be institutionalized? So it does have an impact upon mortality in hospital because we know in that short term, preserving people's function, all that stuff that Amit's done about deconditioning has a real impact upon life expectancy. in the community, the evidence about CGA improving your life expectancy is less good. So again, some of the community data is a little bit less good. And if you turn to that next slide, I think this is lots of stuff like medicine and particularly in geriatric medicine, we end up in an area of greyness. So when you start trying to compare trials looking at comprehensive geriatric assessment, and some show evidence and some less good evidence, it's really quite hard because there are multiple steps that happen really differently. So that all the trials use a different rating scale to assess frailty. All the trials pick up different populations. So there was one trial done looking at, does CGA reduce the progression of frailty in frail older people? And they were using, it was done in females in the community who are over 80, and their mean clinical frailty score was 3. It didn't show a benefit. Joe, that it's really quite hard to get really frail, your clinical frailty score 5s and 6s, to engage in trials, and often they're done in trials that are not particularly frail. So it can be really difficult to pull the data apart about different things. So the population's different, the assessment of frailty is different, how the CGA is done is done differently, and then what do you do with the CGA leads to different interventions. So it makes putting all those trials together in a randomized control, all the randomized control trials in a systematic review, sometimes it means you can't compare one trial with another, and so the numbers in the systematic review fall quite a lot. I don't think, and every geriatrician I think you ever talk to means that that's not evidence that CGA works. It just is about the methodology. It's not as clean and as easy as saying we took 100 people with high blood pressure and gave them this tablet and their blood pressure became lower. It's a really complex set of interventions, really complex group of patients. Just going to the next slide, please. So when should we do CGA? So I think this is the kind of crux of it. So both NICE and NHS England recommend that we start CGA in an acute setting when frailty is identified. So I think that is using either clinical frailty score or another frailty rating scheme. If a trust was using something different to clinical frailty score, I wouldn't have a problem with it. Yeah, let's just use they don't all need to use that. Or people that present with an acute frailty syndrome. So that is presenting with falls, immobility, acute confusion, failure to thrive. So if you go in with a kind of acute frailty presentation, you should have a CGA done. It doesn't need to be completed in the time of secondary care. And this sounds really silly. I think, Maria, are you on this call? Did I hear you? Are you there? Maria and I went to Portsmouth. Yeah, cool. We went to Portsmouth, and what's the name of that team that looks after frail older people that aren't under frailty? Is it the FIT team?
The FIT team, yes.
They do a lovely, there's this roving team of specialist nurses. They do a lovely comprehensive geriatric assessment. It covers all the domains. It's really good. And then we went and talked to them and said, oh, what do you do with your assessment? So we bring them back to the office, and then what? And it was that nice chap over there scans them in. Well, what happens then? Well, we don't know. And so there's only point in doing a CGA if it gets shared. And lots of places are really good at doing really good assessments in secondary care, but they don't go anywhere with them. So if you don't share your CGA, it's not worth doing. And CGA's got to lead to a plan and some interventions. Again, really good at doing assessments, but well, what do you do with it? What does it change? What happens? And people kind of look at you a little bit blankly, like, but we've got this lovely form and we've done it and we're really dutiful about completing it, and we've got really good data about how well we complete this. Well, yes, and what then happens? So for CGA to be effective, it needs to be shared. It's not just one-off in time assessment. It needs to follow the patient and be updated, and it needs to lead to some you doing something. There's no point in doing an assessment if you don't do something with it. And in an ideal world, if we had it, all these would be happening out in the community. I think we recognise that primary care is in a pickle. There are not those teams out in the community, so we are ending up doing lots and lots of these at time of crisis. If they are done before the crisis happens and people arrive with a really good assessment and a really clear plan, it does make life very easy, but it doesn't happen very often. I think there are other times, such as admission to a care home, when it's a really good trigger to do a CGA, that something's happened, things have happened. So the who's part of this. So this needs to be a multidisciplinary tool. It isn't one person completing this on their own. So it needs to be done by a multidisciplinary team. When I taught that in Southie, I got the first one I've used shorthand, forgive me. I think the doctor stroke AMP, what I am saying, this is somebody that can take a history, examine a patient, make a diagnosis and prescribe treatment. And I'm agnostic as to what route that person went down to get that training. So it's not meant to be saying this must be doctors. Lots of nursing issues around continence, nutrition, things that sit there. Physiotherapists, occupational therapists, pharmacists, medicines management and compliance is a really big issue. And then I put at the bottom others that may or may not be appropriate. So speech language therapy and dietetics may be appropriate for everybody. Often those services are only kind of reaching out to really small populations that have got really specialist needs. Older people's mental health is really a big issue. And I've put social work there because I think it's really hard to access it in acute settings. I think in an ideal world, social workers should be part of that core team. I think in the world we're in, that's getting increasingly hard to do. So I'm not wanting to downplay the role of social workers in CGA. It's just recognising that there's a real issue about getting them to be part of it. Just go on to that next slide, please. So if you look at where we should do it, I think the evidence says inpatients have got really good outcomes and really good evidence that it makes a real impact. If you look within that, there were kind of two models. One is everybody goes to, typical elderly care ward where that team exists. And then there are other kind of examples of, well, there's a population of people that get admitted that don't end up under geriatricians, and we've got a roving team that go around it. There's probably, if you look at the evidence, a little bit of extra benefit around that being done in a specialist unit, in a specialist ward, and that's around the stuff that goes on around the assessment, just the encouraging to keep mobility, encouraging to keep active, all those other bits that happen, a little bit like with specialist stroke care. So there's probably a better outcome if you can organise it so that frail older people end up in frail older people's wards rather than being scattered around the hospital having a roving team. But roving team does have better outcomes not doing CJ at all. There's lots of issues around capacity around wards, and roving teams are better than not doing it at all. There's a question, I think, for lots of places about what's the community response after discharge, or if you do admission avoidance, does that CJ happen there? And I think, as I said in that a minute ago, if there's a crisis in the community and acute care need, that seems a really good time to do it. So it's not the CGA. It's not a piece of paper. Completing the CGA is not the goal. There's only point in doing assessment if it leads to some action. If I go into that next slide, I think this is a much nicer picture. So this is using different words, but that flower that we did at the beginning about kind of physical, environmental, functional, mobility, psychological, and looking at medication. So adding medication into those 5 we had on that first picture, but he's saying all those input into assessment. That assessment's got to lead to the creation of a problem list. That problem list got to lead to the development of a personalised care plan and some interventions, and it needs review. So the top half of that page, the purple bits, there's no point in doing that if you haven't got process servers and mechanisms for that blue bit at the bottom. You've got to do something with it. It's got to follow the patient. There's got to be some interventions. Some of those are in the acute setting, particularly the work we do, where we're often looking at frontal, but lots of that happens outside of hospital and out in the community. Just on to that next slide in. So that's me finishing with that. Just wanted to ask for questions, comments. Does that leave people feeling a little bit happier to ask about things going on site? Can we use the not presenting mode?
That's
Has
absolutely
anybody
fantastic. Thank you, Andrew. Emily.
Hi, thanks, Andrew. That was really, really helpful, and I love the patient scoring of their own frailty. I think I haven't seen that actually, but I think that's really. I'm just thinking about that's really quite powerful, and actually that could be quite easily used, I think, in settings. I think just you're right that it's the CGA can be completed and they can do marvelous paper, assessment in, but it is what happens next. And I think that's sometimes the challenging thing, and maybe we don't probe a bit about, because some of it will be around their capacity in community settings of you know, reviewing and planned intervention rather than keeping people in hospital. So I don't know if there's any model, like I suppose it's just, are there any places that do quite well if they start a CGA in the acute and do the urgent, acute and vital components, and then it moves into the community? Because I think that's probably, you know, where we probably need to ask questions about and learn a bit about if it works or how does that happen.
I think that's really key, and I think it comes down to me, electronic patient records and how that's shared. Because if it is, I've completed on a piece of paper, I'll scan it, and you can look at my scan or whatever. It doesn't really work, does it? For it to be a live thing that follows the patient and meets their needs, it's, to me, it's got to be something that crosses that community secondary care boundary. And so often in so many places we go, they're different organisations. They don't share, or you can have read-only access at best, and it doesn't really facilitate that sharing of CGA. I think there is something that is sharing the paper is better than it getting scanned into the secondary care records that nobody ever looks at. And I've been places that do that. Well, what do you do with it? Well, it's there for next time they get admitted. Well, what about trying to prevent the next time they get admitted? Well, what about the community? So I think it's just really asking those questions about how do you share that information, how does it follow the patient, and kind of making the assessment at the front door proportionate to their needs.
That's brilliant. Thanks, Andrew. We'll wait for anybody else to have questions. So the bit that really, I don't know, we've said this so many times around the age cutoff point, but I think those stats right at the start, I think were really illustrated the problem that actually by using age as a cutoff, you're essentially you're not as a cutoff, but for the inclusion towards a frailty service, that you're actually pointing a valuable resource at probably the wrong cohort of patients. And I think just that number was around about 10% of over 65 people had frailty. So I think, you know, just thinking about that sort of, I think that really important piece going forward around the productivity agenda we've got. There's actually a bit of it's more, you know, the CGA and understanding frailty in its whole sense is more important than that age cutoff. I think just that graph in itself, I think just really illustrates the point. So I know we've said it a lot, but for me, that really rang true.
And I think if I'm 80 and get admitted because I got chest pain on the golf course, I probably want PCI done quickly. I probably don't need, you know, that or everyone over 65 or 75 gets the CGA done. I think it is with limited resource, how do we get most value for money? And it is saying we may use age as a trigger to think about frailty. That's okay, but I don't think saying we blanketly do this to everybody over a certain age and we don't do it on anybody under a certain age is the right way to go. And I think that's part of messaging to get out to organisations when we go and talk to them about. That's why there's a sequin for doing clinical frailty score at the front door, isn't there? It's about changing what you do and using it as a risk assessment and screening for cohorting one group of patients that need something different to another. So Richard,
thanks, Andrew. Richard.
I really enjoyed all of that. Really a nice way of putting stuff as well. It's made me think differently, although it doesn't solve some of my problems. So I've been with Norfolk and Norwich this week, who have a model where they have a very strong age process, shall we say, but they've got a very senior team. So they're led by consultants. They've always got 2 consultants in the team, and they pride themselves on their proactive ability to pick out the right patients, but not using a frailty score. So ED frailty score, but they almost did the things you described there, which was undermine the quality of that and all the rest of it. I suppose what I'm trying to understand is, and I understand the stuff about number to treat and all the rest of it, is how do you cut the cake? Because in all these cases, we're rationing whatever model we're using. And I suppose I'm still trying to get my head around whether they're just doing their own thing and it's a really bad thing. Not necessarily bad because they are making a difference for some people, but could they make more difference by ditching the age profile? And Gerft would say yes, but I suppose the jury's out in my head, because you're still going to have to, some people are going to be disadvantaged as a result of how you approach your model. And I suppose I'm trying to find ways of getting them to think more about frailty, but they'd almost argue we're not doing frailty, we're doing comprehensive geriatric assessment on selected patients. So I suppose it's that thought process that's a bit tricky.
I think there is a bit that says if you do put an age cutoff in, you probably capture most frail older. If you do over some places over 75s, over 85s, the numbers of frail 65-year-olds are quite low. I think if you go and talk to some places around the country, so I remember having a conversation with a geriatrician from Glasgow who was saying they've got a really frail population that's under 65 because their demographics are really against them, but no way can you stretch elderly care services to manage kind of multi-morbid, complex, frail 55-year-olds. But those are the people now that are getting really poor outcomes because they're not getting that multidisciplinary team assessment as part of their admission. So I think there's a bit that says lots of hospitals do have antagonism and want something that is binary and black and white that anybody can apply. I think clinical frailty score done by the ambulance probably does deliver that, even though it may be wrong, but it's good enough. But age is the ultimate binary thing, isn't it? You're either 74 years and 364 days or you're 75 years and 1 day. It allows those things without that. Trying to make it patient focused does get into a pinging match of is it my patient, your patient, and who's going to look after them that is difficult to manage on a day-to-day basis. So I think if you have an age cutoff, you may have geriatricians manage the vast majority of frail older people, missing some frail younger people, but within that also managing some people that are less frail. So in my trust, we started auditing the use of recording the clinical frailty score on the admission and post-take ward round documentation of all the consultants. I was the least good because it sounds terrible, but when something's second nature, you don't always record it, do you? I don't think I think of someone's clinical frailty score as I see them. I don't get my phone out of the app and because it's second nature. So I get why in Norfolk and Norwich you may have a group of geriatricians who are not necessarily who are doing it so automatically they're not having to record clinical frailty score and are not the best at using it, but are probably quite skilled at making their level of assessment proportionate to that patient's needs when some are frail and some are less frail. But it's not always applicable everywhere, is it? So someone else had a hand up and put it down. Was it you? Was it
Joe?
Me.
Joe?
It was me. Yeah. So I just on that whole thing about age, because we know, we talk about health inequalities, don't we? And I suppose there is an element of that in this because with the levels of deprivation that you have across the country, as you alluding to Glasgow, their demographics and other things that systems have to put up with in terms of substance misuse, etc., you will get a lower age range for frailty potentially for those sorts of things. So and I appreciate that you can't stretch teams all over the place to pick up everybody because the average age in some places for frailty is under 50. And I suppose then that all sorts of things were going through my head. Then that kind of then thinking about it's called a comprehensive geriatric assessment. So are you going to use it on somebody who's 45 because it says it's a comprehensive geriatric assessment and people that there's a natural association with a certain age range. So there's all sorts of things on there that you could and you don't want to just open up a can of worms. And I suppose from a therapy point of view, maybe we should be suggesting that therapy teams, if you've got elderly people outlying on a general medical ward, that actually their initial assessment, if they want to do an initial assessment, perhaps it's more of a CGA assessment rather than whatever they come up with in their department. Perhaps that might be a way to try and capture some of those outliers. And as you said, emission avoidance, urgent community response teams. I don't know. I mean, I'm making a gross assumption here, but I don't know whether urgent community response would use their initial assessment could be a CGA, because I would think there are quite a percentage of people that they go to who are frail and older. So it's just thinking about whether we can influence that in some way. I don't know. I don't know what other people think, or whether that's just it's just too much.
Yeah. I think some of the problems are they on an elderly care ward. I think the multidisciplinary assessment where you get seen by physio and OT, and the whole MT happens automatically. On lots of non-elderly care wards, because of pressures on workforce, you only get seen by a physio if the ward team asks you to be involved, and so you don't always capture stuff that would happen because people aren't looking for it because the patient's only 64 or whatever. I think just for all of us working in systems, I'm not saying we shouldn't use them, but just a note of caution that yes, there are people under 65 that are frail. None of the clinical frailty rating scales, whether that clinical frailty score or any of the others, have ever been validated as being finding frailty in under 65-year-olds, because that research has never been done. So not to say they're not right, but that we know that whichever frailty tool you use in people who are older has a predictive value about mortality and poor outcomes. We don't know that if you apply that and you find a cohort of people under 65, that necessarily is predicting a group of people with poor outcomes. It's definitely identifying people with complex needs. Whether or not that has a prognostic indication, we don't know. So I would just be a little bit cautious in recommending using CGA evidence or clinical frailty scores in patients under 65. It's fine to do it, but I think we just need to be really clear we're saying this is something that we're extrapolating best practice rather than because there's evidence base to support it. Lee, you got your hand up.
Yeah, so that triggered a few things, Joe, in my mind. So I think there's a few things around sort of therapies I think that could really go here. So I think there'd be I think personally be a bit cautious around every therapy using CGA. I think it comes back down to being appropriately trained. I don't think there's any reason therapists couldn't, the same way as the nurses couldn't. But I think we need to go along that appropriately trained piece. Otherwise, you'd end up just filling another paperwork that probably sits on the shelf somewhere. I do think, though, as you were talking, though, all therapies have priorities, don't they? And I don't think they're aligned to frailty or the CFS. And so suddenly things have actually the therapy prioritization criteria probably should be a bit more aligned. And I do wonder if there's probably some merit in digging a little bit in that from our perspective that we could do, because I think that probably has got some merit. They tend to work in they tend to support a frailty team on a smaller scale, but actually if we're aligned to the sequence, actually there probably is something around the CFS has been done on the front door, how the therapy is prioritizing their workload based on that, because we know these are going to be the people that are probably the most susceptible to that deconditioning and longer term care.
I think in some places they do. Sorry.
Yeah, I was going to say I'm sure some places do, but I don't think it's seen as, I don't know. I don't feel that that's a standard thing. It's probably the better places.
You go, Emily. Go
on. I was just so I know some of the ED therapy teams, they'll either complete the CFS in ED, or they will use it as a trigger from like 4 or 5 to start picking up patients, or if they've come into fall, or the obvious things that would highlight that maybe somebody needs a therapy assessment. So, and I think there's components of the therapy assessment that already align with the CGA around function, home environment, that if they were seen by a physio or an OT, then actually it's, components of the CGA are automatically nearly already done. So it's just a matter of how that fits in to the trusts where the information is being compiled. I know, but it's a good thing to keep in mind for front door therapies, I think, actually. But I do think some of them already work that way, and are trying to incorporate CFS. More probably CFS than the CGA, but something we could look at a bit more.
I think so. I was thinking more of the downstream wards. So I think ED, I think it's quite easy to join up the information, isn't it? And then my experience is the downstream wards don't always join up that same level of information. And so the priorities become supporting discharge as opposed to preventing that deconditioning in a susceptible patient.
And I think one of the problems is if you go back to that slide I put up with the 3 circles, I think on the non-frailty wards, what gets recognised as a trigger to trigger a therapy referral is disability, isn't it? It's the functional impact. We're not necessarily recognising people who are in either the frailty or the frailty and comorbidity circles without, it's probably they've got a walking, they're only 63, but they've got a walking frame. Can you come and see them? Rather than they are quite frail and 63 and don't necessarily have obvious disability and would benefit from that holistic assessment. So I think there is that bit about kind of we're probably missing a group of people there.
Yeah. So I think years ago we used to talk about Paris patients, didn't they? And everyone was like, well, what's the trigger for them? And no one could really give a trigger for them.
Yep.
Patients at risk of increased length of stay, I think is what it was paraphrased as, but there's no really, and yeah, these are these people. Anyway, I'll stop rabbiting on. Any final questions? We've got about 2 more minutes. If not, I just want to have a massive thank you, Andrew, for taking this one. Obviously, apologies for those that there was a few last minute changes in topics. So again, apologies. I'll take responsibility for that one. We'll make sure it's not as last minute next time. But thanks so much, Andrew, for your input. Really, really appreciated. Annie, I think I saw hands quickly go up and go down. Was that a
No, it was because I pressed the wrong button. I was trying to press react.
Brilliant. Well, thanks all, and thanks for joining. I hope you have a lovely rest of the afternoon and weekend, and hope to see you in the next couple of weeks. All right, take care, everyone.
Thanks so much for listening
Thank
and
you.
contributions.
Thank you.